Okay,
Next
so
speaker.
the next speaker and the last presentation, Dr. Tamer Nafee from actually now in Manchester, but he's a lecturer in Alexandria University and a clinical lead at the Create Fertility Center in Manchester. He will talk about ESHRE guidelines for ovarian stimulation in normal responders, the expertise of the Create Fertility Center in Manchester. Please, Dr. Tamer.
Thank you very much, Dr. Mona, and thank you very much, Dr. Hassan and all panelists for inviting me. I'm honored by being here. And thank you for all the distinguished speakers. Now, being the last presentation, I'll try to, hello?
Slideshow.
Yep.
Thank you.
So I'll try to deliver the summary and the take-home messages, really. And my angle and my focus is to summarize the recommendations of this guideline to the normal responders. So it is your normal patient, not the high responders, not the low responders, hopefully the majority of the patients we see. And these are the questions that the guideline attempts to answer, and that we these are the questions that we pose in each treatment for every one of those patients. And again, the focus here is on the patients who are predicted to have a normal ovarian response. So nothing particular about them. So if I have a patient with normal ovarian reserve, a predicted normal response, which stimulation will I be using? Which suppression protocol? Should I pick up a specific gonadotrophin? What dose will I use? And how do I monitor her cycle? And how to trigger her, when and how? And all of these are questions that we take on a daily basis. So it's very good to know what evidence is there, what is the strong evidence, what is the weak evidence, and what are the areas that have no evidence and you rely on what you're comfortable with until further research is up. And the guidelines clearly, as Professor Sankara and Professor Gabi before me highlighted, focuses on evaluating two parameters for any choice you make. The efficacy or the success rate, will this improve the success rate of the patient, and the safety. So if we start with which stimulation protocol, there are two giants, the long agonist protocol and the antagonist protocol, the most commonly used here. So the studies are quite clear that the antagonist protocol would be safer with less instance of ovarian hyperstimulation. But it is, there's no superiority in terms of live birth rates. So from a point of success, they are both equal. Both of them will give us the same number of babies, but it's safer to use the antagonist protocol. Talking about safety and pursuing the point which have just been raised in the previous discussion, then should we aim to be safer and try to adopt other techniques for safety? Should we go lower and lower with the dose and use mild protocols or the soft protocols, decrease the FSH or the dose of whatever stimulant you are using to less than 150 units, for example, 100 units, maybe that's still safer? Well, actually, in normal responders, no, you're not doing this patient any benefit. It's not safer. The incidence of ovarian hyperstimulation is the same, and this is meta-analysis of 5 randomized controlled trials, and the clinical pregnancy rate is the same. So there's no point of going too low. The usual dose of 150 to maybe 2 to 5 can be a very good dose to start with in these patients. Similarly, if you use, for example, clomiphene citrate, or you supplement clomiphene citrate with your treatment, you may even get less eggs, but definitely you're not benefiting the patient, neither in terms of pregnancy rate or in terms of safety and preventing ovarian hyperstimulation. And the same applies to letrozole. If you can see, this theme is becoming recurrent in different presentations, but now we are focusing on your normal patient with the normal ovarian reserve. So there's no point in going too soft, no point in using anti-estrogens or letrozole, and definitely no point in delaying your start the start of the stimulation, for example, to day 5 in an attempt to get still safer stimulation for the patient, because basically you are not benefiting this patient in any way or form. So no point. Antagonist protocol seems to be superior at the usual dose. So the answer to this part, or to answer to the first question, which stimulation protocol, the summary is yes, use the antagonist because it's safer, not because it has higher pregnancy rate. And there is no evidence that you should use any of the other tactics, the low dose stimulation, the clomiphene, tetrazole, or a late start. Now, how do you suppress the LH? Okay, if you want to use an agonist, not an antagonist, if an agonist is what you're comfortable with, there are many flavors there, and we will just highlight what the guideline presents about the evidence for these with or against. So of course there is the long agonist protocol, which we all know that, and that has different shades and grades as well. There is follicular start of the agonist or a luteal start. Some of my colleagues would prefer to start with a higher dose of agonist and then reduce the dose. Some would stop the agonist altogether once they start the stimulation. So all of these are different types of the long protocol. And of course, there is a short protocol where we start the agonist with the stimulation, and this is the ultra short or the microdose flare protocol where you start it and stop it. And we all know these. So what does the evidence say? Well, I must say that the evidence is in large part reliant on the beautiful Cochrane systematic review that's published by Professor Batashari and Professor Gabriel here, and that was very informative. So if we compare the long protocol, long agonist protocol with the short protocol, which as we just realized that most of us, we don't like, this meta-analysis of 4 randomized controlled trials, not a lot of participants, about 300 or so, just said that both of them are equal. But other studies and other randomized controlled trials that were not included in this meta-analysis showed that there is higher clinical pregnancy rate with the long protocol than with the short protocol. And this group I think in Italy, of course, said that the improved outcome is very clear in adenomyosis patient. And that's why I think the ESHRE concluded that it would be best to prefer the long agonist. If you are going for an agonist, then you prefer the long agonist. If you compare the long agonist versus ultra short protocol, it just didn't show much difference in live birth rate or ongoing pregnancy rate. Again, comparing the short versus the ultra short, the evidence does not suggest that any of them is superior to another. But the conclusion and the recommendation was clear. If you are using a GnRH agonist, use the long agonist protocol. Probably it will be recommended over any other agonist protocol. However, you don't have to use the agonist. We prefer that you use antagonist. Again, we are here in normal responders, your usual patient. Why use antagonist? Again, is it more effective? No, it is safer. So probably you will have the same live birth rate, the same cumulative birth rate, in whether you are a long agonist is your thing or antagonist is your type of treatment. But antagonist is definitely safer, and this makes me echo the recommendation which Professor Sankara has kindly alluded to in her treatment, in her presentation, is that if you go for the long agonist, it may be very good to be prudent with the dose, and maybe then use softer stimulation to avoid the hyperstimulation syndrome, because you are more at risk. So the short answer for the question of which suppression protocol to use the antagonist, it's safer. And if you are using the agonist and this is your type of treatment for any reason, the long agonist probably will be better. Now, which gonadotrophin preparation? Just an HMG, purified, highly purified. Do you use the recombinant, the usual ones, or use the new long-acting recombinant? Is there any of them that is more superior than the others? They differ very much in availability in different countries, and they differ in prices. and they differ in our expertise in using them. Some of them have used much more than others. So what is the evidence? Well, this may come as shocking because this was the first line here, the blue box, was a meta-analysis of 11 randomized controlled trials, about 3,000 patients together. And it just said that recombinant FSH may be inferior to HMG in live birth rate and ongoing pregnancy rate. I must say that more evidence has come up, and as we will see in a minute, the recommendation of the ESHRE guideline group is that they are on par together. So you can use the recombinant and the HMG, so there's no superiority of each one over the other. The hyperstimulation syndrome, again, there is none is superior to the other. So at least we now know that the recombinant FSH can be used interchangeably with HMG, and I must say personally, I'm following very much the results of Professor Hassan Ali's randomized control trial that he's doing now. I think this will be very interesting, Prof. So this is the recommendation. It's a very strong recommendation. Use the use of the recombinant and the human menopausal gonadotrophin is equally recommended. They are on par. None is superior. Same if you look at recombinant versus highly purified, whether you are looking at the live birth rate or you are looking at safety of OHSS incidence, it's just the same. So no big difference. We shouldn't sweat over it. Comparing the recombinant against the purified, again, no superiority in live birth rate or safety, no evidence that one is better. Highly purified versus the just HMG, no evidence that one is better, neither in efficacy or in safety. The new recombinant, the long-acting FSH versus the daily recombinant FSH, again, same safety profile for both, and same live birth rate. So my summary here, or the take-home message, is choose what you are comfortable to do with. Choose based upon availability, convenience, and maybe price, because none of them has shown much superiority in normal responders for your normal average patient. Now, what dose? We alluded to the 150 to 225 as being the usual dose, but there is, I don't think it's clearly stipulated. But one thing that is clear in this recommendation, it's based largely on Professor Abulgar's publication, is that increasing and decreasing the dose and doing a lot of adjustments during the stimulation cycle does not alter the outcome really. So you may as well try to come up with a nice plan your treatment, come up with a decent dose that's proportionate to what you think is the ovarian response of this lady, and stick with it, because if you step up at one point, step down at one point, it doesn't really make a difference. Okay, how do we monitor? Of course, we all do the ultrasound scan, and that's basic. But should we do ultrasound scan and something more? Should we use do estrogen level for every patient each time? Will this affect our decision? Will this policy improve our outcome or prevent us from falling into ovarian hyperstimulation syndrome? Thereby, we are safer. We are monitoring more. Actually, the evidence says it doesn't really make a difference. So if you compare cycles monitored with ultrasound versus those that had ultrasound and serum estradiol, this is a group of 6 randomized controlled trials to test the safety, and 4 randomized controlled trials to test the effectiveness and success rates. And both of them just say they are both the same. So by adding serum estradiol measurements, you may not be benefiting the patients either in terms of your success rates or in terms of your safety. Ultrasound versus a full hormonal panel. Some colleagues in some centers would do serum estradiol, LH, progesterone, and sometimes more, and do this even in every single monitoring visit. No evidence that this improves either the pregnancy rate, clinical pregnancy rate, or ovarian hyperstimulation syndrome risk. It doesn't make it safer. So There is no evidence that this should be used. And this is the recommendation. The addition of estradiol measurements to ultrasound probably is not recommended. And the addition of a full hormonal panel is not recommended. It does not improve your success or safety. So keep it simple, cheaper and easier. Okay, when do we trigger and how do we trigger the final oocyte maturation before the egg collection? Okay, for the timing, of course, the follicular size is what we all go by, and it's a clinical judgment, and this is what the guidelines says. Because the studies showed that triggering at anything between, for example, 18 to 22, and in the recommendation just goes down to 16 to 22, did not show much difference in the live birth rate. So there are lots and lots of factors that you have to take into consideration, and this is your own clinical experience based on the patient, on your experience with it, and the number of the follicles, and any other factors that you see that you can take into consideration. Are the group homogeneous follicles or very asynchronous? So this is your call, really. But none is definitely superior to others. Some protocols just recommend delaying the trigger after the HCG criteria by 24 hours, by 48 hours. No, doesn't improve the pregnancy rate. There are no studies to highlight the follicular size plus serum estradiol as a criteria for HCG, or serum estradiol per follicle ratio, divided by the number of follicles to know the serum estradiol output per follicle, and correlating this with the size. No studies there, so the guideline just says we don't have evidence to recommend this at the minute. Maybe future research will. To trigger the ovulation, these are all available, and we have we all know about them. Whether we use urinary HCG, 5,000 units, 10,000 units, we use recombinant HCG, 0.25 or 0.5. We use recombinant LH, agonist trigger, and all types of agonists, dual trigger using HCG and agonist. So there is a lot of noise here. So the guideline clearly shows what has evidence and what doesn't. So if you compare just urinary HCG with a recombinant HCG, it's the same. It's not more effective, not safer to use the recombinant. So the urinary is just as good. Interestingly, using 5,000 international units of the urinary HCG is as equivalent as 10,000. So many use 10,000, but even 5,000 can be enough. It doesn't alter success rates. Same with using 250 microgram, 0.25 or 0.5, 500 microgram of the recombinant HCG. No big difference in safety or ovarian vaccination. There's no evidence to recommend one over the other. Recombinant LH versus urinary HCG, none is superior to the other. So you see, with the lack of evidence, it gives you some flexibility as well, but you also look forward to developing evidence. Agonist trigger, there is a difference, okay? So if you use agonist trigger, the clinical pregnancy rate in the fresh transfer, of course, would drop. So this is something to be aware of. So in a normal responder, I'm not in the context of a high responder here, not in the statistical, just in a normal responder, be careful about doing agonist trigger, because you may drop your success rates. Hello? Yes, similarly, but and you're not much improving your safety profile because it's a normal responder. It's a low risk patient. And these are the recommendations, quite strong recommendation, that the use of the agonist for final oocyte maturation with the conventional luteal phase support is not recommended. And yes, the luteal phase use of the agonist luteal phase support with LH activity and fresh transfer is not recommended. If you use agonist, it's best to freeze. Dual trigger, well, an original systematic review of 2 randomized controlled trials with 300 patients pulled together said that maybe the dual trigger of agonist plus HCG may improve the pregnancy rate, and it's quite exciting to think this way. However, there is other randomized controlled trials that have published and said no, actually it doesn't work this way. Maybe you get more eggs with a dual trigger, but not necessarily ongoing pregnancy rate. So the recommendation of the ESHRE regarding the dual trigger is that we don't yet have evidence enough to recommend using it routinely in normal responders. So the answer to the trigger question would be yes, time your trigger based on your ultrasound scan and your follicular size, anything between 16 to 22 millimeters, depending on your clinical judgment of the case and your clinical experience and your own center. Regarding the medication, agonist is not recommended in normal responders as a trigger medication. Just HCG is urinary is comparable with recombinant. You don't have to go to recombinant. No evidence to recommend recombinant LH specifically. No evidence to recommend dual triggers so far. And if you go for urinary HCG, you may as well use 5,000 as 10,000. It doesn't make much difference, not in safety, not in success. So basically, this is a quick summary of the main questions and the main evidence presented in this very valuable guideline. And just these can be used as guidance for our practice really in the everyday questions. And of course, this we have to keep following up the new developments because evidence changes, guidelines changes, and there are lots of questions that need to be answered. Thank you very much.
Thank you very much, Tamer, for an excellent presentation indeed. Do you have any comment, Dr. Sunkara?
I think it was an excellent presentation, the same comment as you. And the webinar, I think all presentations were excellent. I have to congratulate the faculty for that.
That's very nice of you. Thank you. Professor Tamer, EFRE would like also to offer you honorary membership and boardship also. Tamer has been my colleague for years. We worked together for years. We had very good results and we had very good science and we have very good publication at the time. He's a genius guy.
I'm his student. He just says colleague. He taught me everything about IVF.
Thank you very much.
I owe you a lot.
Thank you. Thank you. Mona, do you have any comment?
I just want to thank all the speakers for excellent presentations. I want to thank EFRE and IPSA for their excellent organization and their continuous enthusiasm. Really excellent in these difficult times to have such a productive and thought-filling meetings. I hope we will continue to do them, and please stay safe and healthy, all of you.
It's wonder we have you all for 3 hours and we have up till now 350 attendees suffering and staying with us till the end.
It's excellent.
So this is very good. Yes. Our next webinar will be on next Friday. It is on freezing all. It will be the faculty will be Professor Yaqub Khalaf, Professor Ahmed Khalifa, Professor Hisham Saleh, Professor Ashraf Abu Ali, and it's a very good webinar. And I wish we can all have discussion, nice discussion, at least for an hour, Professor Sunkara. Not you can stay with us for an hour next Friday.
Yeah.
Thank you.
Right. Say bye to each other.
Thank you for all the speakers.
Thank you
for the attendees and for the participants and for the IT and for EFRE IT. Thank you very much.
Thank you.
Thank you very much. It's a pleasure.